So welcome everyone. Thank you so much for joining today. Dr. Pollycove and I are really excited about sharing topics that we are both very passionate about, trying to kind of help dispel some of the myths and help with more information related to breast cancer screening, lifestyle factors, early detection, and really a whole lot of other things as well. So Ricki, do you want to do any more on an introduction side, or we can go on to the first case?
Well, I just want to say thank you all for showing up. It's if you're around San Francisco Bay Area, it's a beautiful day and you're probably inside. So thank you for taking the time to join us, because as Dr. Peled said, she and I work very closely with breast health and breast cancer and are very passionate to give good information that's useful for women, not just today, but for the rest of your lives, for your friends, for your family, and answer questions as we can. Go ahead.
Great. So the way we thought this would be most helpful today is to do it as kind of a case-based, if you will, presentation. So that way Dr. Pollycove and I can talk about different issues that we see and that come up with our patients. So I think you want to start off with the patient presentation and then we'll go from there.
Sure. And I've tried to use very few abbreviations, but in the interest of not having too many slides, this is a 36-year-old woman who a gynecologist refers for a clinical breast exam. CBE stands for clinical breast. That means done by a professional like Dr. Peled or myself or one of the nurse navigators at the breast center. And so what's relevant when we talk with women and are thinking about breast health and risk for a problem, we wonder how old she was when she started her period. So she was 12 when her menarche or her first period began. She's 5'6", 145 pounds. So that makes her body mass index 23.5. That's very normal. Why that's important is because we know that risk for breast diseases goes up, it increases if women are overweight. And so the body mass index calculation, which you can figure out what your own is by just putting in BMI female on Google, and then you just put in your height and your weight and you'll figure out for yourself. Good history, she had regular periods. Generally that means that her endocrine system is pretty normal. Women who don't have regular periods may have some endocrine or hormone issues that may put them at higher risk. She's chosen an IUD, Paragard, that's very common and popular right now. That does not change your hormones. It leaves your natural hormones completely unaffected. And she's got a multivitamin, curcumin, vitamin E, calcium. So she's kind of on a healthy kick as women go. And she has cyclic breast pain. Well, that's pretty normal if you have regular periods. Often right before your period, your breasts hurt a little bit, and then it goes away after your period. Relevant family history. Unfortunately, her mom was killed in a motor vehicle accident when her mom was pretty young, and the patient was even younger. Her dad is alive, 62, healthy. She has a 38-year-old sister who's healthy and a brother a little bit younger who's healthy. Her mom's mom, so maternal grandmother, that's what MGM means, had cancer of the pancreas and died at age 62. The mom's maternal grandfather, MGF, we don't know about his health. Many times that's the case because if grandparents divorced in that era, you know, grandpa just kind of took off and had another life, and so the adult children may not have known their dad. PGF, paternal grandfather, PGM, paternal grandmother. That means the dad's father and mother both had high blood pressure in their 80s, but no cancer history. So what do we think about this woman, Ann?
So, you know, I think for all of us, and I just wanted to jump in. I see some questions. I've been looking at the questions in the Q&A. Thank you all for already having questions. I think what we'll do is a lot of these, I think, will come up in related cases. So we'll make sure that Dr. Pollycove and I answer them all by the end of the talk. But, you know, I think for both of us, when we see a woman like this, we're trying to assess risk. And so, you know, for many of us, and I think just sort of, you know, thinking about what we do, and we'll get back to our breast slide. But I think when we think about risk, you know, we're trying to get a sense of, is this someone that needs more than a standard breast exam at 36? Is this someone that may have a family history that makes us think like a family member with pancreatic cancer, perhaps, that makes us think that they might need something like a referral to a genetic counselor, or might be someone that we would start screening at earlier. As you said, I think in general, much of this speaks to her kind of doing all the right things already, having pretty common issues like breast pain, but I do think that trying to think through her risk will be an important discussion for her going forward.
Excellent. And I would add too that when a patient's or a woman's mother dies pretty young, we really don't know if that mother might have had a breast cancer had she lived to be 50. And then again, with today's accessibility to genetic screening, all these things can contribute to how Dr. Peled and I are thinking about risk. So my approach to her is I have good information about her lifestyle and her self-care, and I have poor information actually about her family history. But as Dr. Peled pointed out, turns out that pancreatic cancer, colon cancer, and breast cancer are things that we now know may be related to each other in terms of risk, which is clarified by a big genetic study that has gone on for many years. So let's do her clinical breast exam and see that beautiful breast.
Perfect. So I think, breast anatomy can be confusing for people. And someone asked about breast cysts and management after menopause, which might be a great thing for us to discuss after we talk about breast anatomy. But essentially, when we think about looking at the breast externally, as we see on the left picture, when we do clinical breast exams, and when you're thinking at home about doing self breast exams, which I do recommend, both getting a sense of what do your breasts feel like, but also what do they look like? So when you look externally, if you're checking your breasts ideally once a month, you may notice that, do you see any puckering, any indentation? Some women do have baseline nipple inversion, and that may be chronic and persistent for years, or that may be new. And so certainly if you notice any visible changes in the external part of your breast, that would be something to check in with your primary care provider, your gynecologist, or breast surgeon if you have one. The other thing to think about, you can see that the lymph nodes run up along the side of the breast and then up underneath the arm, and then go to help drain the lymph nodes from the arm up heading towards under your clavicle, your collarbone. And so that's a place when you're doing your breast exam, you want to make sure that you're really feeling under your arm, you're feeling along the side of your breast, because if lymph nodes are enlarged, which can happen for a number of different reasons, but that would be another thing that you would want to keep an eye on and let a provider know.
And I would just add that you can see how those pink lobules that are sort of hidden in the diagram to the left, kind of under the skin, but you can see from the side view, as if we were looking at the tissue under the skin, how those lobules might feel kind of lumpy, bumpy, and irregular. And then the channels that drain the lobules that ultimately, if you're pregnant and then become a lactating postpartum mom, that's where the milk would be made. And so they drain through these fine little ductal systems to the nipple. And in this picture, you're not really seeing what I call the guy wires of the kind of connective tissue supports, but all these elements that are under the skin, with experienced hands, we can sort of reassure ourselves, oh, this is a wiggly, soft, very similar to the tissue around it kind of lump, or, oh, this is a lot more firm, it's smooth, it's a little bit tender. That's a classic experience of examining a cyst. Or sometimes very concerning is when we feel something and it's irregular, we can't quite feel distinctly the edge of it. The margin doesn't kind of have that crisp, like a sense of a BB, or like you had a little jelly bean under your skin. So those are the findings that oftentimes, if the breast expert has an ultrasound, a little sonogram in her office, she'll image it right then and there as part of the clinical breast exam.
Perfect. Yeah, we love using ultrasound as an adjunct for sure. So while we're there and you were mentioning breast cysts, we did have this question about kind of management of breast cysts. And this patient, you mentioned breast pain, which can sometimes go hand in hand with breast cysts. And then this question was specifically about sort of perimenopausal breast cysts. I think of you as a perimenopausal expert. Do you have thoughts, Ricki, about how you think differently about breast cysts in this example of a woman in her 30s versus someone coming in with breast cysts in their 50s, let's say perimenopausal time?
Right. Well, and in fact, the transition between your sort of normal regular hormones like this 36-year-old and the menopausal transition, often women produce crazy high amounts of estrogen. So the ovaries are no longer predictable and behaving themselves with the nice smooth hormone production that we see those nice pictures in our textbook, but rather the 40-something, early 50 woman who's having irregular periods has a much higher incidence of actually driving fluid production inside breast tissue than we feel a cyst. And so those are very concerning when they're new, and they're actually pretty common in the menopausal transition. Once final menstrual period has happened and no more hormonal irregularities, which I call boomerangs because they often cause breast pain, they often cause bloating with hormone excess, kind of like early pregnancy symptoms. But I always treat a new finding in really any age group of women with great attention. So the young woman, if her cyst goes away after her period or her lump goes away after her period, that's excellent. That's usually very reassuring. And often, in the 36-year-old who you take her history, her period's due in 2 days, you'll see her back in 2 weeks and repeat her clinical exam. And if the finding is gone, then we're pretty much reassured. In the perimenopause or menopausal woman, often will go ahead and will image these findings because it's a little higher risk as you get older that you will have something that is not benign. And of course, we're not really cycling anymore in menopause. So anything new when we're completely no longer producing hormones on our own raises our concern even greater. So we kind of have different levels of response depending on the age and the presentation. But the perimenopausal transition, and meaning the crazy hormones that can happen on and off for about 8 to 10 years between our 40s and our 50s, very commonly do drive benign breast cysts, but we don't just chalk it up to, hormone being wild and wacky. We go ahead, we usually image any palpable finding with an ultrasound and a diagnostic mammogram.
Yeah, I love that you brought that up because I have to say I'm constantly surprised that I think a lot of women don't know that breast pain, right, as a result of these fluid changes and hormonal changes actually increases in the perimenopausal time. And I see a lot of women coming in who are understandably concerned either they are having more breast pain or their breasts are getting larger, which we also, you and I know as we share patients who we've seen that happen. And I think it's really important that people know that all of that can happen over that extended multi-year period. And while it's something to come get checked out, as you mentioned, if it's a new finding, fortunately, most of the time, it's the normal part of perimenopause.
Yes, we are complicated ladies.
So I wanted to answer while we're on this image, this picture of a breast. Someone had a question about breast implants increasing your chance of breast cancer, and I think this is a good place to put this in. So when we do, just sort of to quickly discuss, when we do breast implants for cosmetic reasons, we're typically putting breast implants in kind of one of two locations. And one of them is right on top of the muscle, underneath that fatty tissue you see. So it's called subglandular, right underneath the gland of the breast. The other is we'll put implants underneath the muscle and kind of release the muscle and make space for them. And the reason this is important is because breast implants in and of themselves aren't typically thought of to increase the risk of breast cancer. There is a very rare type of lymphoma that's been associated with a certain type of implant that's no longer on the market. So in general, we don't think of breast implants as increasing your chance of cancer. But those different locations can make it more or less challenging to see the breast during imaging. So for women who do have implants or are thinking about getting implants, just know you can still have mammograms. The mammograms work well. They have special implant displacement views, they're called, for mammograms. But typically it is easier to see your breast tissue if your implants are under your muscle and it's pushing all the muscle and breast tissue forward, as opposed to over the muscle under the gland. So again, I think for many women, you know, if you decide to have implants, you want to pick the best place for your implants based on discussion with your plastic surgeon. But I typically in my practice tend to err on doing them under the muscle, just as a breast cancer surgeon, in addition to a breast reconstructive and plastic surgeon. I do feel that's often a safer place for implants. But again, there may be reasons to go over the muscle for other reasons. So it's a good conversation to have. But fortunately, it does not increase your risk of getting breast cancer.
I agree. In fact, I find women with implants easier to examine because the implant sort of spreads out the breast tissue and seems to make it easier for me.
I think so as well. So looking at some other things, we kind of talked about this with the last patient, but when we think about, I get asked a lot, you know, how do you know what your breast cancer risk is? And there are a number of factors that we take into account when we think about it. And so taking that history, as Dr. Pollycove mentioned, about what are the family history factors, age and lifestyle. But then we also take into account things like, have you had prior breast biopsies? And if you have, what did those show? And did they potentially show something that puts you at increased risk, like atypical cells? The gynecologic history we mentioned, thinking about when did women start having their periods, or if they've had children. And then breast density is a big topic, which I think maybe we can touch on briefly in terms of the latest ways that we take breast density into account for thinking about risk. So this is a breast cancer risk assessment tool. This is one example, but this one you can find online, and you can actually put in your own history, or you can do this with a provider. And we do this sometimes to think about what your risk might be. And there are other risk assessment models as well. I just saw a patient today who had on her mammogram itself, her risk assessment had been done for her as part of her screening. And I think one of the things I find that's important to remind people of is that the average risk of getting breast cancer in this country is 12%. So we hear about the 1 in 8 women get breast cancer by age 70. So I think it's important to realize that if you hear that your risk might be 15 or 18%, let's say, that might seem like a lot, but that's actually not significantly elevated from what we expect for general risk. So at least for me, I think it's important that we have these kind of numbers to help people decide what level of risk reduction they want to do, or what they might benefit from. Ricki, any other thoughts about sort of assessing risk before we move on to our next patient and talk about mammograms?
Yeah, I like to emphasize just that we are all at risk. And in fact, when it comes down to me, myself, it's going to be 0 or 100%. So with that in mind, I answer that question with patients that say, but I don't want to have a mammogram. There's no history of breast cancer in my family. To which I say, there isn't in mine either. But I also know that most of the breast cancers we find are in fact in low risk women, because such a small percentage of women actually have a family history that gives them high risk. So in fact, we estimate that about 90% of the cancers we find are in women who are, quote, low risk. And that's because so many more of us are low risk. So the risk is kind of, as we talk about it, it doesn't mean, oh, if I'm low risk, I don't need a mammogram. It just says it's less likely they're going to find anything on a mammogram. But because there are so many more millions of us in that category, that is where we often do our greatest good in terms of early detection, because low risk women often would otherwise not be paying attention to their breasts. So that's all I would add.
No, I love that. And I think that's a really great point and ties in perfectly to our next discussion about confusion around mammograms, when to start, what to do. So if you want, we can move on to our next patient.
So here's a woman, and this is, it's so easy for me to pick people out of my practice. She had her period, it actually started a little bit young for her age group at age 10. She's 5'4", 168 pounds. And if you look up that, her body mass index is 28.5. That's actually pretty chubby. And for everyone on this webinar, it's worthwhile looking up your body mass index, because these numbers, you'll see them repeated in all kinds of National Institutes of Health data sets. But for breast cancer, that number is not a good thing. You'd like your BMI to be closer to 25, 23, 22. Those are the normal ranges. So as we get older, and this woman's pretty young to also be already a little bit chubby. And the classic thing is she's had 2 pregnancies. She became diabetic in her first pregnancy. She's diabetic with both. And just sidelight, she was on birth control pills basically until she started having kids. And like so many women today, she delayed childbearing. Her kids are pretty young. And she went off birth control pills after the second baby, and her husband, nice guy, got a vasectomy. So here she is. She's got adult onset diabetes. She doesn't want to take medicine. How many people attending this Zoom would like to avoid medicine? But the reality is, with her track record and 2 young kids and no regular exercise and good intentions, but still a glass of wine a day, which, that's the first thing I would cut out those calories, because that's not nutritious. And that also slightly increases her risk of breast cancer. So this is a patient that I could educate her about so much regarding breast health, just because she's got so many risk factors that are stacking quietly in the night every day, about which she can do a lot. And she's the only person that can really do the risk reduction in terms of lifestyle choices. But let's look at her family history for a second. So her mom is alive. She'd had a melanoma about 26 years ago when she was 55. She is also an adult onset diabetic. Her dad has high blood pressure and heart disease. Her brother had a colon cancer fairly young. Most of us, if we're good patients, we've had our first screening at 50. Many people don't do that, but hopefully we're all convinced that to do your first colon cancer screening at age 50 if you're in the normal population. But if you are in fact this brother's sister or brother, we would recommend that you have your colon cancer screening at age 45. So that's an aside, but I will educate her about that opportunity as well during this discussion about mammography. But she does have a breast cancer on her father's side. Her paternal grandmother had died of breast cancer at 68. And the important thing there for everybody is that breast cancer genetic risk can be transmitted from male parents or female parents. And so to say, oh, well, it was on my, grandfather's side, well, that can be transmitted to any family member, because these are not sex-linked transmissions. So anyway, also we now know that prostate cancer also may be associated with elevated risk of breast cancer in relatives. So in fact, this family history, in addition, you add Ashkenazi, the Ashkenazi Jews, about 1 in 40, when we do genetic screening, carries a gene that increases risk of breast cancer. So this is the patient that I'm so glad she came to me from her previous doc, because I can help her stay healthy and understand why, and probably Dr. Peled would agree, that among the value of a mammogram at age 41, and I recommend an annual mammogram at age 40 and above. Not only would I recommend that, but personally, I would send her for genetic counseling, and either to our breast center through the nurse navigator or through our separate genetic counseling division, to at least have a consult to help stratify her risk and become more aware. What would you say, Dr. Peled?
I completely agree. I think, as you said, there's so many opportunities to make general interventions around breast health. And the wonderful thing about breast health interventions is they're just good overall for your health. And so we know that exercise is linked to decreasing your chance of cancers in general. I will say, I think it's one of the important things to keep in mind is that, like we were talking about, many women who get breast cancer, people who get breast cancer don't have a family history. Well, similarly, unfortunately, you can be active and quote unquote healthy and still get breast cancer. And so we don't say this to sort of say that, if you get breast cancer, you got it because you're overweight, or that you're not going to get it if you're healthy and exercising. But it's more to think about kind of where are there places that we can take better control, be active in our health. And so certainly when it comes to alcohol, people ask me about this a lot. And when we look at a curve, once you start getting over about 4 to 5 drinks per week, you start kind of going up into a curve of increased risk of breast cancer. So certainly if I have patients in my practice who have a strong family history of breast cancer or at elevated risk, I do try to recommend to stay at that 4 drinks or less a week. I know it's been challenging for everyone with COVID, but it is one of those things that trying to keep an eye on alcohol consumption is really important. And then again, I think with an Ashkenazi Jewish background, certainly genetic testing would be covered. And so it would be worth getting that information. So I think we talked a little bit about really getting to know your risk. And so one of the things that people bring up is that genetic testing can be scary. If you think about it, getting this information that you might be at increased risk for not only breast cancer, but other kinds of cancers, that can be a scary thing to think about. And so I see people sometimes who probably would benefit from genetic counseling or testing, but don't go because of their fear of those results. And I would say in that scenario that, knowledge really is power, and knowing that you're at increased risk potentially, or finding out that you're not, whichever that is, it still gives you the power to think about taking control, doing more screening, making choices, talking to family members. So I think that certainly that first step, as you mentioned, of the genetic counseling part of it is really helpful, because then you get a sense of your family history and can find a test that's right for you. So I think I wanted to see sort of some questions that we had around here around perimenopause. So I think this would maybe be a good time. We can talk about this patient and then think through some of the things around, hormone replacement and diet. And in that setting, I think this would be a perfect patient to sort of talk about some of those issues with as we move forward, and also talk about mammograms and other screening.
Right. And this is, again, a very typical woman. She's been super healthy. You can see she's tall and slender, and she's had no pregnancies. She had menopause actually at a normal age. The average age is 51, but the incidence of menopause is not considered early as long as it's after age 40, which especially a lot of women at 48 are just sort of feeling like they're hitting their stride professionally, and it's kind of shocking when the period stops, like, oh gosh, I guess I'm grown up now. But she started using a transdermal estrogen patch, estradiol. By the way, all transdermal patches are bioidentical. And she already loved using a levonorgestrel eluting IUD. The brand names of these would be something like Mirena, Skyla, Liletta. Anyway, we are lucky to have a variety of them, but it does a brilliant job keeping the uterine lining thin in menopause too. So many women go through this very graceful menopausal transition without any abnormal bleeding because they already have the IUD. She's our ideal woman. She exercises 7 hours a week. And that seems amazing, but an hour a day actually, especially if you divide it, you do maybe a 30-minute walk or a 30-minute workout in the morning, and then always after dinner you take another walk. Well, that's going to be 7 hours a week. And then of course a little bit of free weights, stretch bands, whatever. But she's a non-smoker, she's a vegetarian, and if there's anything she does regularly that slightly increases her risk, it's that She does have 2 glasses of wine a day, even though who knows it's not making her overweight. So she's substituting wine calories for other food. But the other thing in her history that actually slightly increases her risk of breast cancer is that she's never had a child and never breastfed a baby. Although, you know, our risk reduction, you'll see when you fill out your form at the mammogram center, they ask you if you've had a baby and were you under 30 or over 30. These are weak risk contributors, but when you look over a giant population, the women who've had more babies have less breast cancer as a group. So it didn't make her high risk that she didn't have kids, it just did not lower her risk. But here's her family history. Her mom had ductal carcinoma in situ at age 56. So DCIS in situ means it wasn't an invasive cancer, but when Dr. Peled said if you had a previous biopsy or a prior history, having ductal carcinoma in situ at age 56, we have watched her mother carefully, because having that's not a terribly young age for DCIS. It's actually pretty close to the average age, but it did put both her mom at greater risk. She's still alive and well, but then the mother's sister, so the aunt, had an invasive breast cancer, probably in the perimenopausal, you know, age 49, and had a mastectomy and has done fine. But again, that's 2 relatives, a first degree, your mother, a second degree, your aunt, with slight elevation in risk. Then the dad, again, like so many men, high cholesterol, but he's on statin medication, so that's controlled. That would not contribute, that we know of, to breast cancer risk. Paternal grandmother had some abdominal cancer and died fairly young. When a patient gives me that kind of history, I'm thinking, was that an intestinal abdominal cancer? Or was that maybe ovarian cancer and never diagnosed? So this is enough family history with the absence of genetic testing. This 51-year-old who fears radiation, who's reluctant to have imaging, I would send her personally to the Breast Health Center for a thorough nurse navigator educational session. And that would include not just, you know, imaging and answering all the questions that the radiation from the mammogram does not increase your risk for breast cancer, and also information that would probably incline this otherwise healthy, doing everything she can, except she maybe drinks a bit too much wine, but really encourage her to explore genetic counseling and testing. What would you say, Dr. Peled?
Yes, I agree. I think that the concerns around mammograms we see regularly. I think, as you mentioned, it's really important for everyone to know that getting mammograms, the radiation from that is very minimal, and that it does not increase your risk of future cancers, and that we know from big studies. People ask me a lot about alternatives to mammograms. We are going to talk a little bit about the use of MRI later in the talk. But whole breast ultrasound is a question that comes up regularly. The answer is that here in the Bay Area particularly, we don't do whole breast ultrasound as a screening tool in most people. And the reason for that in many ways is because for those of you who've gotten a mammogram, you know that your entire breast goes into a machine. You see the breast all in one view up on the screen. With ultrasound, you're moving around the breast in all different spaces, and you don't get that full view picture of the whole breast in that way. So ultrasound is very good for if you know something that you want to look at. So either you find something on ultrasound, on mammogram, or you find something on exam, or you have a localized area of pain. Ultrasound is very good at that, but it's really not great as a screening tool because it kind of sees too much that you can't put in context. So,
Like the needle in the haystack.
Sorry, was that?
Sort of like the needle in the haystack.
The needle in a haystack, exactly. So again, I hope this makes all of you who may have concerns about radiation feel safer about getting mammograms, and the benefit, which we'll go into, is very real. I would love to talk again, sort of taking your expertise on this, because we have so many questions about explaining the concept of using hormone replacement therapy, risk of breast cancer, and kind of the concept of how we think about hormone replacement in that perimenopausal time. I know that could be like a 6-hour talk in and of itself, but if maybe you have kind of some quick tips and sort of framework for people before we move on to talk some more about mammograms, because there are several questions about that specifically.
So the use of transdermal estradiol, bioidentical estradiol, does not increase your risk of breast cancer. And the woman who basically is keeping her uterine lining thin and healthy using pretty much a local only IUD is basically in the risk category, which is a risk reduction, probably around 10% lowered risk of being on estradiol compared to women on nothing. And that may surprise people, but an even greater study is our own Women's Health Initiative. So the Women's Health Initiative has many, many arms, a lot of behavioral things, nutritional things, observational sets. It had 2 hormone groups. One hormone group had hysterectomies already, and so they only got estrogen, and they got a one type, Premarin, and that is the conjugated equine estrogens that were originally distilled from horse urine, pregnant mare's urine, Premarin. So the American data set used the first ever symptom relieving, FDA approved in 1942 hormone compound. That's one group, estrogen only. The other group had their uterus and they received the Premarin and a progestin, medroxyprogesterone acetate. And therein is the subtle but measurable difference, because there were 26,000 women in this randomized, blinded, long observational prospective trial. So in the women who got the MPA, medroxyprogesterone acetate, with their Premarin, we saw actually not a statistically significant increase in cases of breast cancer, but what we did see was those women who got breast cancer had higher death rates. That was with the MPA. This woman, in our case, on bioidentical estradiol, she won't have the 22% incidence reduction we saw in the Women's Health Initiative in women who are on estrogen alone. She'll have about the 8%, 10% that we see in the European data. But what's most important for everyone to remember is that either the bioidentical estrogen like this woman has or the conjugated equine estrogens do not ever cause breast cancer. In fact, the reason we see a lower incidence in women exposed to estrogen is because of a very interesting deep biology that's been proven both in tissue culture, but then the Women's Health Initiative estrogen only trial proved it in humans, which is this process of programmed cell death of cancer stem cells. So it turns out we actually have, kind of disconcerting, but we have a lot of cancer stem cells in our breasts that our little army of metabolism is going through on a regular basis and snuffing them out, just like a candle snuffer putting out the flame. That process, which is built in, amazingly enough, is actually enhanced in the presence of estrogen. The rare tumor cells that escape that process early on usually still have their estrogen receptors, and that's where the confusion comes in. So the typical cancers we find early, the vast majority still have estrogen receptors, and we can treat them, and women generally survive very well, and it does not impact their long-term survival. So the earlier we find a breast cancer, the more likely it is to still have estrogen receptors. This is where the confusion comes in, because now if you have an abnormal cell with an estrogen receptor, we don't want to stimulate it with estrogen. So that's where, as something you take away from this lecture, it's even more important to have mammography, because it is in mammography that we find these very early, treatable, curable breast cancers. In fact, in our breast center, I think our number, last I checked, was about 96% of breast cancers that we find at the CPMC Breast Center are cured with simple surgical excision and maybe some hormonal therapy. Is that about where your data?
Yeah, the stage one, our survival rates are very good, as you said, in that mid to high 90% for early stage breast cancer. So we do a very good job treating those.
And the vast majority of those, we can't feel them yet. They're kind of microscopic. So I hope you've gotten your confidence up that not only is mammography a valuable screening tool, but it is in applying it widely across our, quote, healthy population, that we're going to find those rare times that the healthy processes that keep all of our cells behaving themselves and in check, when they go haywire, if we find them early, they are less nasty and more curable. So this woman left the office with her mammogram slip in hand, and she wound up having a normal mammogram, and she also wound up having genetic counseling, and she has one of these new rare, not breast cancer gene 1 or 2, not BRCA1 or 2, but one of these other sort of associated genes. And so now she's going to the high-risk surveillance clinic, and she's also cut back on her wine consumption.
Good work. So you got her all sorts of good information, which was great. We're gonna talk a little bit more about mammograms, but I did want to answer a couple questions that I felt like tied in well. There was a question about people who've had estrogen receptor positive cancers and soy. So again, I think soy is a big topic. I'm sure I get all the time. And I think the answer to this is that much of the data that we see related to dietary factors, nutrition, and breast cancer is conflicting and confusing. My general take home on soy, though, is that the amount of soy you need to actually have a negative impact, either increasing your breast cancer risk if you haven't had breast cancer, or increasing your breast cancer recurrence risk if you've had it, is incredibly high. So I say don't do 4 soy lattes a day, but don't give up your 1 soy latte a day. So is that what you tell people when you ask about soy? Because when I've gone through the data, the amount of soy you would need to consume is just so high to hit any increased risk.
Yeah, I think one of the things I've learned practicing here is a lot of women think if a little is good, a lot must be better. And because a lot of the protein powders that women put in their smoothies are soy based, that's where the proteins come from, they're actually getting a ton of soy. And when we look at the data that we observed 30 years ago about Japanese women having very low breast cancer rates in Japan, and we look at what Japanese women consume in terms of soy, it's in food. It's either tofu or it's actually edamame soybeans. So they're not putting scoops and scoops of protein powder into a smoothie. So what Americans do is we like to package stuff and make it easy. And what we've learned increasingly is let's get back to basics. Let's eat the whole food. And the only time we see some real endocrine or hormone interferences with soy, as Dr. Peled said, is when people get these isoflavone isolates. So high concentrated nutritional supplements, which I really do not recommend. They don't reduce our risk of anything that we know of. And there are data that show they actually interfere with bone, and you can actually increase your rate of bone reabsorption. So again, it's like we are not eating soy the way the native traditional soy intake of Asia has occurred. If we can get back to that, probably that is the healthier way to eat. Plus they have a very high fish diet, very low red meat diet. We know red meat increases total body inflammation in general. And just as Dr. Peled said, whatever you do that reduces your risk of breast cancer, reduces your risk of colon cancer, and reduces your risk of dementia and heart disease. So it's a real win-win situation once we get our lifestyle in hand.
Exactly. Agreed. So I wanted to just go on we've covered some of these, but just to sort of think about mammography. And these are real facts. There are, as so many things in health, some misconceptions, but the reality is that mammography has reduced breast cancer mortality by almost 40%. And they can look and actually directly attribute that to picking up earlier stage breast cancers. And so as Dr. Pollycove said, we catch them early. we reduce the chance that it's life-threatening. As we talked about, and I think there was a good question on here about skipping a mammogram every other year. And someone asked about being told that if they didn't have findings, that it was okay to have mammograms every other year. And what I would say to that is using these data is that, skipping a mammogram every other year would miss up to 30% of cancers. And so it's a nuanced and complicated topic. They're doing a study run out of UCSF right now called the Wisdom Trial. And what the Wisdom Trial does is it actually looks at a number of different factors. So your family history, your breast density, your personal history, all the things we've been speaking about, and they help randomize you, either it's randomized or standard, to a specific regimen of mammographic screening. And while I think from a population level, thinking about how we screen people and have tailored screening is really important, I think about if you are an individual with mammograms being very low risk, none of us like it, it's not comfortable, but mammograms are low risk like we've spoken about. I think most people, when they really think about it on an individual level, would rather get that yearly information rather than waiting and potentially wonder if they'd gone the year before, would something have gotten picked up when it's at a lower stage, it's more treatable, even if it's the same surgery, it's in potentially an easier surgery. So I would say, on a personal level, in terms of what I would do for myself, my family members, my patients, I recommend annual screening mammography starting at age 40. I actually recommend continuing for many patients well into their 80s. The reason for that is that people are living longer, they're living healthier. And I saw one of my 86-year-old patients today who doesn't take any medications, which is amazing. And she's incredibly healthy. And so for her, if we could pick up a breast cancer early, it really probably would make a big difference for her. So I think, again, that's individualized based on your other health issues. But I do think that continuing screening, certainly through your 70s, makes a lot of sense. I don't know if you have other ideas about what you recommend in terms of age, since we had a couple of questions about that.
Yeah, I think it really is based on the functional overall health and vigor of the woman. And, many women who are vigorous and healthy and 80, if they come to me and they say, my internist said I don't need any more mammograms, she sort of feels like her doctor told her that, we're just going to put you out to pasture and not worry about kind of preventive medicine anymore. And I totally agree with Dr. Peled. It's really, the mammogram is a tool for a healthy woman to stay healthy. And we look at other intervening factors, and certainly the 84-year-old woman who has severe heart disease, if you get a mammogram and it's abnormal, so now are you going to subject her to a biopsy? And, we've all seen good intentions pave the road to hell. So in women with severe other causes of disease that are likely to be very high risk for ending her life in the next few years, many times we are not going to do a mammogram in that patient because the way we follow up on it may precipitate an event that's lethal for her. So it's pretty rare in someone in their 80s that a breast cancer that is only detectable by mammography would change her life expectancy. So this is where it's clinical judgment, or what we might call common sense, but somehow it may not get articulated in a kind and gentle, understandable way to patients.
Yes, exactly. We do not want to give the heading out to pasture feeling to people.
Right.
So again, I think as we both do regularly, it's really about shared decision making, understanding people's priorities and concerns, and coming up with a plan together. I did just want to, we've blown through this hour very quickly, but I did just want to finish up with a couple of things. The first one was, I think that this, in my mind, this graphic, I think is really helpful for people thinking about mammograms to know that although 1 in 10 women who go in will end up needing some additional testing of some kind, whether it's a diagnostic mammogram, an ultrasound, or even a biopsy, only 5 out of 1,000 women who get screening mammograms come in to actually find out that they have breast cancer. So I think just something to think about, again, to hopefully take some of the fear out. And then even in those 5, as Dr. Pollycove mentioned, the vast majority of those are going to be treatable with breast cancer. So I hope this takes out some of the fear with that. So I think what we'll probably try to do, again, since we've gotten through, I think, most of what we wanted, is maybe to quickly do some of these questions in here before we finish up. So this one I think is interesting, better for you than me, I think, but a link between ovarian cysts and breast health. Do we know any correlation between the two?
That's pretty interesting. So, of course, as a gynecologist, I'm thinking, well, how old is the patient? So, ovarian cysts in younger women, basically, not to make you nervous, but every woman who ovulates and menstruates every month makes a cyst, usually about a inch to an inch and a half in your ovary, tends to go back and forth. So, like the woman with the IUD who had regular periods, she was making cysts on her own every month. When women say, I have a cyst in my ovary, she may be talking about a functional cyst or a dermoid cyst, things that are bigger and not associated with ovulation. Functional cysts, usually they go away if we suppress ovulation. So the traditional way of doing that was to put young women on birth control and see if the cyst goes away. In fact, right now with the big uptake and embrace of IUDs in young reproductive age women, we're seeing a lot more ovarian cysts again, because when contraceptive hormones, birth control pills or NuvaRings were kind of 95% of women chose that, we saw very few of these functional cysts, which are those cysts that make estrogen. And when you're younger, you may not notice the hormone effects, but you may notice the pain. Those significantly do not increase our risk for breast cancer, nor do birth control hormones increase risk for breast cancer. So every year, the World Health Organization puts out an estimate of breast cancer incidence and survival rates, and then they go back and they look in every country that has birth control pill hormones available, what are the statistics? And basically, it's incredibly reassuring that at whatever age a woman starts birth control hormones, whether pills or rings, she does not increase her lifetime risk of breast cancer in any clinically significant way, nor does she impact in an adverse way or a harmful way. She does not impact survival. So I would say in general, having a routine functional ovarian cyst has no impact on breast health. The women who have, quote, polycystic ovarian syndrome, that's part of what I was hinting to with the first slide about the woman who had regular periods. Women with polycystic ovarian, it actually is kind of a metabolic disease, and it increases risk for a lot of things as we get older. For one, it increases risk of adult onset diabetes, but anything that increases your overall body inflammation impacts your cancer risk for all cancers in an unhealthy way. So polycystic ovarian patients are at slightly increased risk for breast cancer, but their major risks are metabolic, much more in the blood pressure, heart disease, diabetes category. So these are things that, as a gynecologist, I actually worry more about uterine cancer in those women than breast cancer. Having a dermoid cyst does not increase your risk of breast cancer. That's a very common type of cyst in young women that we usually remove them if they get to be about an inch or two, just because they generally get a little bit bigger with age. After a cyst gets to be about 5 centimeters, it's a little more likely to rupture on its own. We don't want that with dermoid cysts. So, a cyst in your ovary could be many things, but in general, they do not increase your risk of breast cancer later on.
My favorite question so far was a question about how to start doing mammograms if you haven't started. And that is so great. And I love that you're taking that from this. So really, honestly, anyone can give you a mammogram script, if you will. Typically, most people find it through their primary care doctors or the gynecologists. So if you have one of those, that's a great place to start. And mammograms are a covered benefit in terms of being recommended for screening for ages. So that should happen. So,
and one of the questions that was posted on the chat, I have peripheral neuropathy since Taxol. Those are the kinds of questions that you should come back next week, because yes, that's much more the getting into the nitty gritty details of advances in breast health and breast cancer care.
Exactly. And we'll have a medical oncologist. Thank you for that reminder. One of our medical oncologists, who's wonderful, will be on next week talking specifically about it.
I did want to add one other detail. That's one of my favorite details regarding hormone therapy, the question. The greatest difference, estrogen alone, not with the medroxyprogesterone, but estrogen alone or estrogen with progesterone in menopausal women is actually long-term survival if they get breast cancer. So the relative risk was smaller, but the huge difference is if I'm diagnosed with breast cancer, I'm 50% less likely to die of breast cancer than a woman who was not on estrogen at the time it was diagnosed. So that's a very significant effect. And I think we kind of, as a culture, medical culture, we don't tease out the details, like, because as you could tell, it's a lot of words in your mouth, but these details are very important. And that's why increasingly those of us who do a lot of hormone support for menopausal women, we really take away the fear if we have the data and we can share it with women. And this data came from our own Women's Health Initiative at the 20-year reanalysis, looking at the women who are on estrogen alone and all the outcomes. So they had less heart disease, they had fewer fractures, they had less colon cancer, they had less breast cancer, but those who did get a breast cancer have had, as of 2018, which is when that data set was cut off. So the article was published in July of 2020, but it ended in the data collection in 2018. Anyway, so as of that time, they're significantly less likely to die of breast cancer. So to me, it's a little bit like having diabetes. If I can have a disorder, it increased my risk. If I had ductal carcinoma inside or an early invasive ductal breast cancer or lobular, but with good management, it's probably not going to shorten my life. And that's kind of my attitude towards moving forward with our choices. You know, so much is lifestyle. As an older woman, let's see, I've had now about 15 years of experience with menopause myself. So I feel like I'm a member of the demographic to which I serve a lot of my daytime. But it's very reassuring when you actually look at the information and don't get scared away by, oh, estrogen causes breast cancer. Well, let's get some information. As Dr. Peled said, another beautiful article that just came out from the British literature, which is especially important to me because what does Great Britain have? They have national health. It showed in their clinical trial, and they're all about saving money too, that when women are screened annually between 40 and 50, not starting annually at 50, but annually between 40 and 50, they saw significant reduction in death rates from breast cancer. Other thing Dr. Peled and I both know, sadly enough, the younger we are when we're diagnosed, often the nastier cancers are. So it really makes a bigger difference in terms of life years saved if we have started annual screening at age 40 for all of us, really, not just the high-risk women. As we said, only about 10% of women are high risk. So it's the 90% of us that are going to contribute the greatest benefit as a nation that wants to reduce suffering and improve quality of life.
Yeah, I think that study is so important. And I think continuing to think about, you know, what is the right time and individualizing that. Because honestly, for some women who do have that risk, 40 may not actually be young enough, you know? And so it may be that, like you were saying, that example of colon cancer. So I actually was talking to some of our colorectal surgeons recently, and they're really concerned that we're seeing more younger people with colon cancer. So they are actually recommending that people think about, like you said, screening even earlier than 50 and thinking about 45 or even 40, depending on your history. So I think making sure that you have that conversation with your provider about your family history, deciding if 40 is right or it doesn't need to even be younger. The other thing that we see a lot of is I get people checking in about whether or not mammograms are effective in younger women. And so that gets into our question about density, right? And so for those of you who aren't aware, breast density is now it's actually part of the state of California requires that your mammogram report comments on your breast density. And then the reason that's important is that the denser your breast is, the more difficult it can be to see through it with mammograms. So we like having the opportunity of thinking about seeing that through that better. And so one of the ways we can do that is with a type of mammogram called a 3D mammogram with tomosynthesis. For those of you who may not join us next week, yeah, exactly. So as Dr. Pollycove was showing, it goes around like this, your whole breast. And for those of you who may not join us next week, I hope you will, but if you can't, we're actually moving our breast health center here at CPMC over to a different campus and have a whole new set of 3D mammograms, which I'm really excited about, because especially if we're screening women who are in their 40s or potentially even younger in their 30s, 3D mammograms can be really helpful for women with denser breasts, which can also extend, you know, women into their 70s too, but it can be really helpful for seeing through breast tissue better. So I think that, again, that's something to think about if you are a person who's getting mammograms, hears that you have dense breast, a good opportunity to talk to your provider about if 3D mammograms might be a better choice for you for seeing through tissue.
And by the way, sadly, every woman gets the same letter. After her mammogram, the letter you get has a paragraph that says, your mammogram shows that your breast tissue is dense. This may obscure small masses, blah, 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 blah. So I go over the actual report that I get and the Dr. Peled gets, which actually stratifies your density into very low density, mostly fatty, scattered fibroglandular. About 1 woman in 7 has that. Then most of us are in the category of heterogeneous density, average risk. Mm-hmm. That's where the 3D mammogram, where the camera actually moves subtly. Your squish and your squish feel the same, but if you look carefully, you'll see the mammogram machine actually moves. So we separate out tissue density just like a computerized tomogram scan of your belly, CAT scans. So yeah, it's basically kind of like a CAT scan of the breast. And then about 15 or 11% of women are extremely dense, and their breast looks very white. And I remember years ago, our chairman at the breast center, Jessica Young, she was giving a talk and she said, yes, when breasts are extremely dense, it's like trying to find a polar bear in snow. And, you know, that's just such an apt description, because we can imagine that that would be pretty tough. So why we now have new tools, especially if you're high risk from your family history, where you've had previous atypia or atypical, you know, hyperplasia, those diagnoses, then you're put into the group where you may in fact have periodic MRIs. And again, that's going to be next week's discussion, but this is our job. I say our job as a primary care breast person is to stratify risk and refer you appropriately. And unfortunately, with the pressures of time on most clinicians, you know, I don't think you get this discussion at your 15-minute annual visit. So it's where you are your own primary care provider, being the little drumbeat that I beat, which is to say, ask questions, be informed, and then when you request something of your primary, like if you're 41 and you haven't had a mammogram, you really should. And if they disagree, well, it's a free country and you can seek another provider.
Yeah, I completely agree on that.
I'm pretty pro empowering women to be their own best representative.
I could not agree more on that one for sure. So looking at some of the other questions on here, there was one about what could be a cause for the increased risk of breast cancer in the Bay Area? And that is a great question that I think a lot of us have thought about. And so hopefully you can hear from both of us about it. I think one of the things to think about when we diagnose breast cancer is that the more we screen, the more breast cancers we find, but they're earlier stage. And so one of the things to think about is in the Bay Area in general, we tend to do a better job following up on health care recommendations. We have a lot of physicians here. We have reasonably good access to care. Obviously that varies among populations. So in general, women are better at getting mammograms here. So inherently we're going to find more breast cancers.
The other reason that we appear to have more breast cancers here in San Francisco and Marin actually is from socioeconomic strata. So it used to be, until a couple months ago, very expensive to live here. And so we know, interestingly, that higher socioeconomic status and lower parity. So I'd mentioned earlier, the woman who's had no children or only had one child is at slightly higher risk for breast cancer. And again, that's across the population. But if you look at breast cancer incidence in Marin and you correct for low parity, so the average parity in Marin is 1.14, which means, as one of my patients said, it means that most women in Marin have a cat. But it just means that actually very few women in Marin have had babies compared to the population. Well, partly that's what happens when the cost of living gets very high, because who moves in is not necessarily putting kids through school. So, I mean, these are hidden factors, but for those of us who followed the Bay Area breast cancer rates since the 1980s, as our socioeconomic status has gone up and our birth rate has gone down, these two factors have increased the population who's at higher risk. And actually our census tracts, we have census tract data, Pacific Heights, where we're sitting right now at the California Pacific PAC campus, the Telegraph Hill area, Nob Hill area have the highest rates of breast cancer, Seacliff also in San Francisco, actually higher than Hunters Point, which is not well known, but it's sort of fascinating. We can break these down. And the same is true in Marin. If you look at the census tracts where the home prices are highest, you have higher breast cancer rates, which is backwards from what you think, because you think, oh, well, the wealthier people go to the gym and they can afford all organic food and all that. But there's some population impact of very low birth rates that we see that, by the way, all over the world. Low birth rate, slightly higher breast cancer rates. So.
Yeah, so these are great questions we're getting through. So we're getting a couple nutrition questions, which I know Dr. Pollycove, you talked about recently, but I was thinking maybe we could do is nutrition a high priority when thinking of breast health and cancer prevention? And then also talking about vitamin C and what foods that's in and how that plays a role in our breast health and health overall.
Well, I think probably the healthiest way to look at nutrition is to look at what actually lowers total body inflammation. And now the evidence is becoming increasingly clear. It isn't a supplement. It's actually the food. And so, interestingly, there's a whole smoothie, now you can have very fancy, healthy, blended drinks delivered to your door. So people are going for the quick, but it looks as though like the value of kale is greatest when you actually eat kale. And part of that is because there's something about the fiber in its natural form. And then the balance, I mean, think about how we evolved. We evolved eating food, not eating pills. And so I'm really an advocate to go back to nature. You'll actually spend less money if you cut out a lot of your needless supplements. And honestly, there's a lecture, I think you can pull it up in the archives, that we did back in September, really taking supplement overuse to task. And so I would just say in general, if you can, organic, just to avoid pesticides and heavy metal contamination. And secondly, the whole fresh vegetables. And when you learn about what is amazingly in the actual whole fruit and whole vegetable, you'll see, wow, I really don't need many vitamins. Probably the only one you really need is vitamin D for most of us because we use sunscreen. Vitamin D is actually a hormone. It's important in anti-cancer cellular function in all of us. It's also important in anti-COVID, all viruses. The part of our immune system that handles viruses is very similar in terms of vitamin D dependency to the part of the immune system that snuffs out early cancer cells. So one of my big encouragements is there are very few foods that are very high in vitamin D. Mushrooms are relatively high. So is cod liver, but most of us don't eat a whole lot of fish liver because it's pretty strong, unless you're Norwegian. But I think these are the things that I do prioritize healthy eating because, for example, if you look at colon cancer, there's really no supplement that reduces colon cancer risk like eating a broad plant-based diet and not being overweight and not drinking to excess. And having high fiber. So a lot of people take their fiber in the form of, teaspoon of this or their benefiber. But, I also wonder as a skeptic, how much of this is driven by corporate, profits, because, they don't make money as much off of food. The lowest margin business you can be in is selling grocery store food. But that's probably what's best for us, farmers market. What do you think, Dr. Peled?
I agree. I also think a lot of this is about your mindset for it. And what I tell people is it's really hard for those of us, which is I'm sure, unfortunately, all of us on this call who've ever tried to quote unquote diet. It's really hard being told things that you can't have and trying to take things out of your diet. So I love the idea of plant heavy. Plant-based often kind of brings to mind like you can't have certain things and you can't have dairy and you can't have meat products and you can't have that. But if you think plant heavy, you're just actually getting to add things. So if you think about, what kind of plants, vegetables, bright colored foods you like to have and add those to your diet, I think you're getting all that benefit without feeling like you necessarily have to cut things out. With the exception of, like we talked about, I think moderate alcohol is worth cutting out. But everything else, I think you can think about it as adding. So definitely that in my mind, both for myself personally and also for people that I see who ask about it, I think that tends to help. And then you're hitting all those vitamins that you mentioned. And someone did ask about vitamin D, which I'm so glad you brought up. And I will say that I think it looks like more and more providers are checking vitamin D levels regularly, which I love. But again, as thinking about you advocating for yourself as a patient with your primary care doctor, if they're not checking vitamin D levels, I would ask for it, because I do think that's an important thing that many of us are deficient in and we don't even know.
In fact, most women that I screen are deficient to one degree or another. And again, I love medical anthropology and evolutionary medicine, because that kind of gives me, it's like being on the hunt for where we came from and how we got out of the cave. Mm-hmm. And the fact that we did get out of the cave, that's pretty awesome. So what was the balance that allowed us to evolve as humans? So I'm kind of a back to nature doctor, as much as I love living in the modern world and having technology like this that can help us bridge the gap during COVID. But I also think that when you look at how native people lived, we exposed our skin to sun and we kept synthesizing. We make vitamin D as humans through our skin, and we would keep making vitamin D until our blood level was 100. If we continue to get sun, like lifeguards and swimmers and people are outdoors all the time, volleyball on the beach people, they will inactivate vitamin D if they get sun all the time and they reach 100. And so that really is a set point naturally of humans. I find that just fascinating. And then you look at our lab norms, they have 30 to 100. Well, that's because so many people are D deficient. And so it pulls the average down. And internists are very confused because they look at, like, Institute of Medicine, a little research study came out. It was a 2-year clinical trial in 70-something-year-olds. That doesn't relate to my patients. Very few of them are 70-something. Most of them ask me these questions are in their 40s or 50s. So I think there's a place for common sense. And in the absence of checking your vitamin D level with COVID outside your door right now, I would advise everybody to take 5,000 units a day. That's how much vitamin D you would synthesize if you stood outside midday, open neck, no sunscreen, sleeveless, just your bare arms, your chest, and your face. You would synthesize in 15 minutes 5,000 units through your skin. Of course, we're not going to do that because we put our sunscreen on. We don't want to get skin cancer. So we've really created vitamin D deficiency by virtue of preventing skin cancer. So I'm all for preventing cancer. Otherwise, Dr. Peled and I wouldn't be doing what we do. But it's like we have to compensate for certain adjustments we've made as longer lived humans. And that's the part that I find pretty delicious. Like, okay, if we're really going to hang around for 80 or 90 years, we didn't used to have that opportunity. 200 years ago, only 5% of us lived to be even 50. So this longevity thing, even worrying about breast cancer, that's actually a new opportunity. So not to be cavalier, but to say, let's take a look at this new opportunity. And that's why we have to change our attitude and put a little more effort into our younger years so that we're not like that famous joke, gee, if I knew I'd gonna live to be 80, I would have taken better care of myself. So that's the task I give my patients in their 40s. I would say, between now and your next visit, I want you to see if you can name 5 women 80 or older in whose bodies you'd be happy to live.
I love that.
Pretty hard.
Yeah.
Like, oh, I don't want that one. She's sort of crippled with arthritis. Oh, I don't want that one. You know, so this is where it's kind of like reality check. And I always say, you're worth it. You're number one. And so that's why you're your primary care provider, and really prevention of everything nasty that we don't want. And we haven't even talked about cognitive decline and dementia, but these are the things like quality of life kind of starts right here. Of course, it really is your heart and all the love you have inside of you, but you know, all these other things, they all weave together, and happily they tell the same story. So what reduces breast cancer risk in nutrition and exercise, lifestyle, hydration, vitamin D probably. You know, I don't have a clinical trial. I'd probably be, you know, long since gone from the Earth's surface by the time we've proven this. But again, logically, I know the data from 2010, the breast cancer population diagnosed that year in the United States, their average vitamin D level was 17.5, severely deficient. So, okay, it doesn't say that's why they got breast cancer, but it's really not a good thing. So anyway, I could go on.
So many good tips though, and thanks for all of us. I love the thinking about being 80. I'm gonna do that one by the next time I see you. So that's a particularly good one.
Great picture, every wrinkle.
So I think now that we're actually at the correct end of this, I think we can answer this one last question, which is great. And this is about having breast sensitivity most of the time and what this could mean. So I think that sort of like we spoke about earlier about breast cyst and hormone levels, the answer for that is it really depends a lot on where you are along your spectrum in terms of your life and what kind of things could cause breast sensitivity. I can maybe speak in, you know, my practice, especially with my younger patients, and then, you know, some of your perimenopausal patients, what you see. But, you know, for me with breast sensitivity, a lot of it tends to be cyclical for women who are still having their periods, and definitely that hormonal impact. For many women, it's that week leading up to their periods. There are some women who tend to have more sensitivity around time that they might be ovulating. But in most cases, when you really track it, and I do recommend when people come in with breast pain, they try to keep track of it, because you may not think about or realize that it's happening at the same time every month if you're just living it. The other thing I will say is I've seen a lot more breast pain since COVID, and most of the women I talk to, it's because they're having a ton of coffee, because they're home and they're not necessarily in their same office environment, and they're home and having more coffee. And coffee, we know, really does increase breast pain for some women very significantly. So the dietary factors we see, caffeine, alcohol can make a difference, chocolate, things like that. So again, if you are having breast sensitivity, worth thinking about, are there triggers, and a journal of that can really help.
The other thing that reduces breast sensitivity in general is cardio, exercise, and sweating. So, you know, total body salt, water retention on a fine basis probably causes a little more tugging of some of these tiny supportive tissues in the breast that trigger the nerve impulse that says, ouch. So that's another thing. You know, it's never harmful for us to do a little cardio. And one of the things I've noticed with COVID, contrary to what you might expect, because a lot of women only did cardio when they went to the gym. So since the gyms have been closed, yeah, and the weight gain's gone up. And so most women, when we gain weight, we gain it disproportionately in our breast. As we get older, we stop menstruating. The glandular tissue that was there that was fibrocystic, we have less of that. That's why mammography gets easier as we get older. But similarly, that tissue is replaced by fat, which takes up a greater volume. So most of us will gain about half a breast size, even if we don't get overweight in menopausal transition. But I think the absence of exercise and the stress and weight gain have contributed to a little bit more breast sensitivity.
Yeah, no, that's a great one that I hadn't even thought about with the cardio, but that makes total sense. So good. I'll recommend people look at their cardio and their coffee now. So.
Cardio and coffee, CNC.
Well, great. Well, I think we got all the questions. Any last minute things to add on your end, Ricki? Anything?
Just a pleasure to see you, Anne. And actually, Dr. Peled and I are next door to each other now. She moved her office this past year, but we never see each other because we're busy inside. But hi.
So many great questions from all of you who've attended. So thank you so much. Really appreciate your joining us. And again, hopefully some of you will join us next week as we move into some more cancer focused topics.
Thank you. Thank you so much, Dr. Peled and Dr. Pollycove. And thank you to all of our attendees for your wonderful questions. This was such a lively discussion between the doctors, and I highly encourage you to attend our talk next week at 4:30, 10/21, that's Wednesday at 4:30. I will be sending out an email after this event so that you can have that registration information directly in your inbox. We hope that all those of you who didn't get to ask your questions will bring those same questions to our talk next week. We have 5 speakers lined up from CPMC Breast Care Team, and it's going to be a wonderful and exciting discussion.
And share it with your friends.
Yes, share it with your friends. This is not just for women, because men are in women's lives, and it's good to know about this. It's good to have this information for your loved ones.
Great. Thank you, Twin, so much for organizing and doing such a great job coordinating all of it. And thanks, everyone.
Thank you for joining us.
Have a good evening.
Bye, everyone.
Bye-bye.